Yeah, in the last years, the use of neuromodulation has been widely increased, but on an exploratory basis, not only to improve cognitive function, but also to improve other symptoms like fatigue or spasticity. But in recent years, from success and failures, we found out that the best combination of using these tools is with training, whether it is like cognitive training or exercise or rehabilitation, because both interventions work on the mechanisms of plasticity, so there could be a synergistic effect on that. So what we did was to combine intensive neurorehabilitation performed on an inpatient basis for 3 weeks, together with transcranial magnetic stimulation with excitatory type of stimulation, so high frequency. And that was for 3 weeks in the evening after 2 sessions of rehab. Actually, the intervention was 5 days a week for the first week, and then 3 days a week for the second and third week. And what we found was that over an extended battery of tests, that the most responsive measure was the endurance, the resistance to fatigability while walking. And this is measured using the 6 minutes walk test. How many meters can a person perform in walking 6 minutes? And also with the endurance, which is how long can you walk before you just stop the first time. And what we found is that the significant effect was much higher at follow-up, at 3 months follow-up, because the people undergoing sham stimulation, which is giving the same type of noise and scalp sensation, that was delivered with a special device which is called H-coil, that it has the capability of stimulating deeply below the skull, so to reach the leg motor area representation that lies deeper below the skull. So many of the failures in improving lower limb function and walking in people with MS with neuromodulation, I think were ascribed to 2 things. One is that the stimulation was not reaching the exact target area, and that we overcome this with the appropriate device. And the second was that the interventions were too short, like 5 days treatments, and so this would not be enough. So we try to find, to put together the best combination. But I think that the 3 weeks were not even enough. Maybe 4 weeks would have been better, because what we find is that people in the sham, so the apparent stimulation, go back down. Although they improve because they undergo intensive rehab, they go back down to almost close to baseline, while people who have received the real stimulation keep improving or stay the same. And so this is important if we consider the mechanisms of plasticity that require continuous rehearsal, and probably the sort of gain that was obtained with magnetic stimulation was kept perhaps because of continuous training by the people when they went home. And this is opening another area of study in people with MS, which is remote monitoring, because we are seeing in these years an explosion of technology, not only for brain stimulation, but also for remote monitoring using sensors and devices. There are many options and that are being under study. And I think this is one example where the use of sensors during the follow-up would have benefit our knowledge in knowing why these people were kept their improvement, because my guess is that they kept their motor activity even during the follow-up. And another issue would be the baseline predictors of response. And so advanced neuroimaging, including the optic nerve assessments using evokepotentials, but also the neuroimaging of the retina, measuring the axonal layers and the neuroaxonal layers, have been stressed as an important determinant of future progression of disability. But we don't have enough data on the neuronal reserve at baseline to predict the possibility of improving during an intervention that could be rehab or even pharmacological intervention. So I think we have much to do yet in the exploration of predictors of response and predictors of maintenance of this response. Our next steps would be to perform a trial with hopefully longer duration, but allowing to measure the activity of the patients when the intervention will stop using sensors, so that we can better see what are the mechanisms and the indications to give to the people with MS about what to do when they are discharged of the intensive rehabilitation interventions.